Hello and welcome to the launch of the Centre of Excellence in Treatable Traits. We hope you are going to have a great evening with us this evening. I'm Dr. Vanessa Clark and I'll be your chair for the evening. But before we begin, I just want to cover off some housekeeping things. So welcome to everybody joining us from all around the world via Zoom. I just ask that you keep your microphones on mute during the presentations. Depending on time, we will pause for questions after each of the presentations, and we will have a dedicated Q&A at the end of all of the presentations. For those online, if you'd like to ask a question, you can use the Zoom function to raise your hand, or you can enter it into the chat on Zoom. For those in the room, we have a roving mic, and we ask that you ask your question into the roving mic so that the people online can hear. For those of you in the room, just a reminder to sign in as per our COVID protocol and maintain physical distancing. Our toilets are located outside this door and if you walk around the auditorium. Before we commence the evening, I just wish to pause to acknowledge the traditional custodians of the land in which we meet today. For us here at HMRI, it's the Pambalong clan of the Awabakal tribe. I extend the respect to all Aboriginal and Torres Strait Islander people here today and pay my respects to the elders past, present and emerging. I also acknowledge my presence as a guest on these lands and recognise that I stand here on country today that people of Aboriginal and Torres Strait Islander descent have had a connection to for thousands of years. I acknowledge the cultures and traditions of the Aboriginal and Torres Strait Islander people who have nurtured these lands for over a millennia. So it is now my pleasure to introduce Professor John Upham, the President-elect of the Thoracic Society of Australia and New Zealand, to provide us with an opening address. Thank you, John.
Thanks, Vanessa. Thanks to Naomi and for everyone involved in the CRE for Treatable Traits. In one sense, I come as an outsider, and in another sense, I come as an insider. As an outsider, I'm speaking to you as someone becoming the Thoracic Society president as of tomorrow, but I'm also an insider. I'm part of the team, and it's really a delight to be here to see this Treatable Traits CRE launch and really get started and do some exciting things over the years ahead. Now, we're all aware that problems around complex airways diseases have been with us for a very long time. And I think one of the great opportunities of the CRE is that it gives us a way of looking at some of these problems with fresh eyes through the lens of treatable traits. And that together with the team that's been assembled, I think is really what makes this so exciting. So we have people on the team from a really diverse number of backgrounds, from different professional streams. And as we partner with consumers, I think that's going to be particularly powerful in addressing some of these complex problems for which we'd like to see innovative and transformative solutions. It's inevitable over the years ahead that some of the ideas that we have now and some of the plans and the endeavours that we put in place are going to go really well. Some things will flourish and turn into outcomes, to understandings, to ways of approaching problems that'll transform the landscape for patients who suffer from complex airways diseases. But it's also inevitable that some of the ideas and some of the plans that we have in place now are going to lead up a dead end. Some of the ideas are going to fail, but that's not necessarily a bad thing, because being able to, the falsifiability test in jargon, that being able to show that something doesn't work is actually part of the process in finding out the best solution for our patients and the complex problems that they face. Part of making progress in understanding and coming up with new solutions inevitably involves some degree of failure along the way. And you don't have to look far beyond the example of Thomas Edison, who tried many materials before he invented the electric light bulb. And in some sense, every failure that he experienced along the way was actually a step closer to achieving his ultimate dream of a functioning electric light bulb. Many years ago, someone said to me that to succeed, you have to be free to fail. And I think as a CRE, we have to be free enough to fail. We have to be brave enough and innovative enough that we will try things, knowing that some of those things are going to fail. Because if we stick to the safe, if we stick to the predictable, the likelihood that we'll make significant advances is vanishingly small. So I don't really want to take up too much of your time. There are plenty of other speakers who will probably have a lot more detail to go into, and we'll flesh out some of the things that the CRE will be doing over the coming years. But congratulations to you, congratulations to us for having got this far, and I'm really excited to see the journey that we go on over the next few years. So thanks, Vanessa.
Thanks so much, John. That was fantastic. Good way to open. It is now my pleasure to introduce Professor Vanessa McDonald. Vanessa is a Professor of Chronic Disease Nursing for the School of Nursing and Midwifery at the University of Newcastle, and she's the Director of the Centre of Research Excellence in Treatable Traits. Vanessa is going to provide an introduction to the centre.
Thanks, Vanessa. Good evening, everyone. Wrong slide. Here we are.
A-metals. Severe asthma is controlling my life. It is controlling my life, totally.
You regulate the things that you can and you can't do according to that.
I can't sit and not do nothing.
I feel tired all the time.
I couldn't breathe. Really gets hold of you.
You have to think about where you're going, what you're going to be doing before you go there.
Things I couldn't do because of the illness, I would just leave me absolutely breathless.
Well, you can't do it because you haven't got the lung capacity to do it.
I can only do so much now.
Being restricted in everything I do.
That does impact on your mental state.
You know, my lungs are sort of being treated. You still have other effects.
Can't say to my kids who are all working, come and hold Mum's hand because she needs more help.
It's a tricky sort of illness, I suppose.
You can feel lonely.
They don't really appreciate how much it does impact your life.
Just never worrying that you're not going to be able to breathe. I think that's the biggest thing.
Yeah, the big problem is just having it, really.
Understanding your condition and working cooperatively and productively with the people who are managing the condition with you is really, really critical.
Our asthma is individual. There's so many different kinds out there, and we all feel different things.
So, listening to these sound bites, you hear the voices describing the ongoing burden of people living with chronic airway diseases. The voices describe the impacts. I can't breathe. I'm restricted in everything I do. They identify the contribution of comorbidities. It impacts my mental state. My lungs are treated, but there are other effects. They speak of the pervasiveness of airway disease. It's controlling my life totally. They acknowledge the need for effective patient-clinician partnerships. So working productively and cooperatively with people managing the condition with you. And not at least, they recognise the heterogeneity of airway disease. Our asthma is individual. We're not the same. This is the purpose of our CRE. The purpose of our CRE is to revolutionise healthcare for people with airway disease. We'll do this through the use of treatable traits so that we can improve the lives of people living with airway disease and improve health outcomes. I want to acknowledge the Consumer Reference Group for sharing their experience with us so that we can get some understanding of the impacts of airway diseases on people living with it. We'll aim to revolutionise airway disease with this CRE. Here is our team. It's a formidable group of people that are represented from many areas. We have 20 investigators, chief investigators and associate investigators, and they're based here in Newcastle, across Australia and across the world, including Brisbane, Canberra, Melbourne, Oxford in the UK, Wellington in New Zealand, Spain, Barcelona in Spain, and Sao Paulo in Brazil. It's an excellent team that we've put together here who will work together to achieve our goals, and I'll talk about those a little bit later on. This slide here just shows the collaborators. So not only are we partnering with institutions in health and university institutions, we have also partnered with peak body organisations and consumer bodies, including the Thoracic Society of Australia and New Zealand and Asthma Australia. So we're really excited to be moving forward with this. This is the official launch this evening. We received funding at the end of last year, so we've had a couple of months to get our act together, I suppose. And we've established a really great team of people supporting the research. We've recruited some research fellows, some PhD students, and some assistants in communication and marketing. We hope that this list of people within the centre will grow as time goes on, and so that we can continue and build on the research that we'll present this evening. I also want to acknowledge the role of the Consumer Reference Group. So we've been working with this group for some time now, and they've worked with us to co-design some of the research activities within the centre and within our grant application. We find that that's been really great for us to be able to put in the perspective of people living with disease in the research that we seek to achieve. So thanks to everyone that's part of this. And I won't say anything further now, but we'll pop back up later after the next two fabulous investigators present the evolution of treatable traits, and then the revolution in what we're going to do to change practice. So thank you.
Thank you, Vanessa. That was extremely powerful. Thank you for that. Okay. So it is now my pleasure to introduce Professor Ian Pavord, who's joining us all the way from England this evening. Hi, Ian. Hi. Ian is a Professor of Respiratory Medicine at Oxford University and a Chief Investigator for the Centre, and he is going to provide an overview of the evolution of treatable traits. Thank you, Ian.
Thank you very much, Vanessa Clark and Vanessa McDonald. I'm absolutely delighted to be a part of this Centre of Excellence. I wish I could be with you now, sharing a glass of wine, but it's a funny world we live in at the moment. So I'm going to talk about the evolution of this idea, this new way of thinking about airways disease, the treatable trait concept. I hope everyone can see this slide and my conflicts of interest, which are set out here. So this, for me, started in January 2013 when I was at an ad board in Zurich. Remember those days when we used to be able to travel? And I was asked to speak on the future of asthma, and Alvaro Augusti was at the same meeting, and he was asked to speak on the future of COPD. And we essentially made the same point in our talks. And it's summarized in the text on the top of this slide from John Bell, who's the Regius Professor of Medicine in Oxford. And I think these words are very relevant to the situation we're in airways disease. So we diagnose them as if they're homogeneous entities using criteria that really haven't changed since William Osler's days 100 years ago. And that treatment is generic and empiric as a result. And what we needed to do was to move away from this system to one which better matched patients to treatment and allowed us to apply treatment in a more precise and effective way. In essence, we should stop looking for treatments for asthma. We should look for a treatment for a asthma. So we need to pull people out of this heterogeneous population. And I think the driver for this perception that we needed to change were a number of things, but one was key outcomes. And this slide shows asthma mortality in various countries. And I want you to focus really on the thick red line, which is a sort of amalgam of global mortality. And this is mortality in young people where there is unlikely to be much diagnostic confusion. And it's shown over the last 60 years. There are two major eras during that time, the bronchospasm era and the inflammation era. And I want you to focus on the far right of this graph, because this key outcome has stopped improving in many countries over the last 10 years. And in fact, in some countries, including the UK, there seems to be a slight increase in mortality and hospitalization rates over the last 10 years. Now, to put that in context, the cardiologists have delivered a 70% reduction in mortality from ischemic heart disease in the UK in adult men during the same 10-year period. So that's a worrying contrast. We're also bottom of the league table, or at least we were at this in 2015, when it comes to delivering new molecular entities to marketable drugs for our diseases, with only 3% cumulative market entry probability for a new treatment. So like Leicester City, my football team at the time, we were bottom of the league. This is an important league. And those new treatments that we got, we nearly missed the beneficial effects. So mepolizumab, a monoclonal antibody that blocks IL-5 and inhibits eosinophilic airway inflammation, was evaluated first in the Flood-Page study, a reasonably big study of patients with moderate asthma, as defined by bronchodilator responsive airflow limitation. That's how we define asthma. And looking at a related outcome measure, the morning peak expiratory flow, this study showed no evidence of efficacy. But when the drug was evaluated in people that had the treatable trait eosinophilic airway inflammation, as reflected by induced sputum findings, and when an outcome measure that's linked to that process, asthma attacks, was evaluated, the clear benefits of this treatment were evaluated. So when you have a system for thinking about and classifying airways disease, which results in you nearly missing the beneficial effect of a drug with the sort of life-changing potential of mepolizumab, you really do have a big problem, I think, that needs to be addressed. And in essence, what we recognized was that there are at least two relatively independent treatable traits that are driving our patients' problems. In order to get a full picture, you really need to assess both of these. So we have eosinophilic airway inflammation, which is linked particularly with asthma attacks, but also an abnormality of airway function, whether it's variable airflow obstruction, fixed airflow obstruction, cough reflex hypersensitivity, which is more closely linked to the symptoms our patient has. So these are, if you like, relatively independent treatable traits. And it's become clear that assessing eosinophilic or type 2 airway inflammation is one of the most important things you can do in a patient with airways disease. There's now very clear and consistent evidence of a relationship between biomarkers of this process, the blood eosinophil and FeNO, and the risk of asthma attacks, with between a 3- and 5-fold increased risk of attacks in people with high biomarkers compared to low biomarkers. And it doesn't matter if they have mild asthma, severe asthma, or COPD, the same basic premise holds. And this data, I think, can be viewed as FeNO and blood eosinophils are a bit like the airway cholesterol and blood pressure. They are markers of modifiable risk. And Simon Couillard in Oxford has been playing around with data from a number of big clinical trials and has come up with this beautiful asthma attack risk scale, which I think could be used in primary care to assess the modifiable risk of asthma attacks. And this is a hypothesis, might help patients make better treatment decisions and doctors make better treatment decisions. So that's the background of the evolution of this idea. The idea actually came from Alvar Augusti after a couple of glasses of wine in the evening of that meeting. Again, do you remember when we used to do that? But it was a good way of having ideas. And Alvar, although he's not a native English speaker, has a genius for catchphrases. And that's where treatable traits came from. And it could be defined as a measurable aspect of the disease that can be modified with resultant patient benefit. And clearly, eosinophilic airway inflammation and airflow limitation would be examples of treatable traits. And this concept was really a very big part of the Lancet Commission published 2 or 3 years ago, which Peter Gibson and Richard Beasley and Alvar Augusti were a big part of, and I was very fortunate to chair. But we weren't the only ones thinking about this. This is a lovely paper from Vanessa McDonald that we received thorax at the same time. And it looks at a new approach to assessing and managing COPD, which they called a multi-dimensional assessment with tailored interventions, where various biomarkers and clinical features were assessed in a formal, structured way, and interventions were targeted depending on what was found. And this lovely title, Respiratory Utopia or Common Sense. And the study showed, I think, quite clearly that when you adopted this multi-dimensional assessment, which is essentially a treatable traits approach, you achieved better outcomes for these patients with COPD, and the biomarkers of treatable traits were modified in the direction you wanted them to be. So clearly the same idea was happening in Europe and Australia, and we very rapidly got together and combined forces. I think the essence of treatable traits is that one should always assess the 2 dominant treatable traits. The risk of attacks as a result of eosinophilic type 2 airway inflammation, and the presence of symptoms as a result of airflow limitation. And that allows you to begin to target your treatment more effectively. So your approach for a patient with inflammation predominant disease and we see a lot of these in the severe asthma clinic, would be steroid and biologic heavy, whereas your approach for a patient who has symptom predominant disease, and we see a lot of these in the COPD clinic, would be more bronchodilator heavy. One of the key benefits of this more structured approach to assessment and management of airways disease is it shines a real focus on patients that have neither of these problems, because what's driving their morbidity. So this approach will facilitate the recognition of other treatable traits that drive morbidity and key events in patients with airways disease. And I think there are a number. This is a list of what I would regard as the more important and well-validated treatable traits that might be seen in a patient with asthma or COPD. The top two look really very like we have good treatments and good predictive biomarkers. And the others will be very familiar to you. And they, of course, exist across the pulmonary, behavioral, and environmental domains. So the treatable trait concept has developed. There are two gatherings I've shown photos of here. The first on the left in Barcelona, and the second on the right in Newcastle and Melbourne. I believe we've had two meetings in Newcastle and Melbourne. And the concept has developed. I'd like to highlight a paper that Dominic Shaw's just had published in Lancet Respiratory Medicine, which takes the concept to the point of diagnosis. I think a much more sensible, feasible approach to diagnosis of patients with airways disease, where the labels are de-emphasized and the key treatable traits are emphasized. So you can see different algorithms depending on whether you have type 2 high disease or airflow obstruction. And of course, in people that have neither of these traits, an early look for other potentially less well recognized but clinically important treatable traits. So I'm going to finish there. This is a treatment strategy that I think is radically different to our current approach. The indication for treatment is the presence of a trait or versus the presence of symptoms and or perceived risk. The goal of treatment is to normalize the trait or biomarker versus suppression of symptoms and or exacerbations, which may, of course, be related to an entirely different process. There is compelling evidence, and I just showed one study from Newcastle, but there are many more, that this approach is superior to current guideline-based management in asthma and COPD. To me, it looks eminently feasible in non-specialist care, and let's not forget that it's primary care doctors that have delivered the huge improvements in outcome in cardiovascular medicine by doing biomarker-directed targeted risk reduction. So I'm sure they're capable of doing this for airways disease. One of the important benefits of this approach, it will shine a focus on what we can't do in airways disease. And often in medicine, I think knowing what we can't do is as important, if not more important, than knowing what we can do. And identifying the unmet need is going to be of enormous importance for the pharma industry. Thank you very much.
Thank you very much for that, Ian. If Ian's talk has generated any burning questions for you, please speak now or forever hold your peace until the Q&A at the end of the session. Any burning questions? None online? All right. Well, with that, it is now my pleasure to introduce Professor Peter Gibson. Peter is a respiratory physician and clinical researcher for the Department of Sleep and Respiratory Medicine for the John Hunter Hospital, and he is also a director of the Centre for Research Excellence in Treatable Traits. Thank you, Peter.
Thanks, Vanessa.
1 and 2. And thanks, Ian, for your presentation. It's great to see those pictures of the meeting we held in Newcastle, which was on the beach. So people were dividing their attention between the waves and the content of the Treatable Traits meeting. That's why it took us 2 meetings to get a single publication. So severe asthma and COPD are high burden illnesses, and they affect people in many areas of their lives. Whilst we have treatments, the response to treatment is variable. Some people do really well, but others have a poor or incomplete response to treatment. And people with these diseases have to juggle not only their asthma and COPD, but also other comorbidities and risk factors. This places an ongoing burden on their quality of life. In the Fighting for Breath survey, people with severe asthma were having troubles in 2005, and then they were still fighting for breath 10 years later. And you can see some of the areas that their lives are affected. Symptoms, disturbed sleep, but importantly, participation in social and work-related activities. So there's an ongoing burden. And progress has stalled. So Ian alluded to this in the UK. Here are some data from Australia. Both mortality improvements and hospitalisation improvements have stalled. We had a real problem here in 1990, and it was a concerted national cooperative effort that led to major improvements, and we were able to halve the death rate and reduce hospitalisations. But we're not seeing further improvement. We still have a persistent sort of, if you look here, a flat line in children being hospitalised for asthma, and the same with people dying from asthma. So it's reasonable to ask, can we do better? What can we do different that will address this levelling out of asthma outcomes? Here are the faces of some people with asthma and airway disease. Now, you can see that they're very different. Yet our treatment approaches are telling us to treat them all the same. So when people have persistent symptoms, whether they're a young boy with allergy-driven asthma or an older man with asthma driven by other features, they're still told to increase their treatment in the same way. Now, when I look at these pictures, that doesn't make sense to me. And I ask the question, can we do better? What happens if we don't recognise that heterogeneity? What we see is limited efficacy of our current treatments. We see over-treatment, so you just keep escalating doses in the face of persisting symptoms. We know that they're both problems we have with asthma in Australia. We also don't deliver new therapies if we just don't recognise the heterogeneity. Ian showed you an example of that with anti-IL-5 treatment for severe asthma. For me, as a doctor, I have to juggle things that don't make sense in practice. So a really useful intervention is action plans, teaching people with airway disease to respond early to their symptoms, intervene and prevent a severe attack, prevent hospitalisations. And every different disease has got its own action plan. The trouble is, patients aren't just one entity. They might have both asthma and COPD, or both asthma and bronchiectasis. So how do I reconcile which action plan I should pull out of the drawer for the patient? By mapping the traits, so by looking at more detail, we can start to get an insight into this heterogeneity. So this was a key study done by Ian's group in Leicester at the time where they did map the traits in people with airway disease. And the young boy with allergic asthma, he had a close relationship between his inflamed airways and symptoms due to bronchospasm. And he would do very well with the traditional approach to asthma. But this young woman, she has quite severe nasal disease, probably polyps, intense eosinophilic inflammation. And she will end up overtreated without much response and needs a different approach. And people like this respond very well to targeted monoclonal therapy. In contrast, someone can have lots of symptoms, but little in the way of airway inflammation. Steroids for them won't help. And so the treatment here is back titrating the steroids and finding alternative management strategies. So mapping the traits can give us some insight into this heterogeneity. Another piece of this puzzle has come from precision medicine or targeted therapy. There have been 3 big advances in respiratory medicine in recent years, in 3 very significant diseases: severe asthma, lung cancer, and emphysema. They're all different treatments, and in these 2 columns, those treatments were compared in randomised trials using an unselected approach, just the standard diagnostic approach, or using a targeted therapy or approach where you target the treatment to the trait. In every case, in the unselected approach, the trial was negative. It was concluded the treatment didn't work, but it wasn't until you identified the trait, identified the people with the trait, and targeted the therapy to them that you saw benefits, whether it was reduction in exacerbations in severe asthma, survival for lung cancer, or exercise tolerance for emphysema. If scientists didn't target therapy, we would have concluded that these treatments don't work. They would have been chucked out. The patients would have remained with the burden of their illness. So the science is also telling us that there's another approach that addressing heterogeneity can deliver new treatment approaches. And this is what patients are telling us. People with airway diseases are telling us that their asthma is individual. There are so many different kinds out there, and we all feel different things. This is the argument for treatable traits. It's an approach that accommodates those issues I've just shown you. It's essentially a model of care. It's how do we take effective treatments, bundle them up, and deliver them to the people that need them. It's simple, ABC. So you assess traits, A for airway, B for behavioural and risk factor traits, C for comorbidity. And the meeting in Melbourne and Newcastle, I think one of the significant outcomes of that meeting was clarifying what constitutes a trait. And it's 3 factors. It has to be clinically relevant, has to be identifiable and measurable, and it has to be treatable. And the treatable traits approach seeks to apply these things in practice. As Ian said, we'll come up against things that are untreatable, and that goes into the area of future discovery research. Here's a list of traits across those areas. So airway, they're listed here, behavioural and comorbidity. You might look at that list and say, that's daunting. I look at that list and say, here are treatment opportunities for people. Not every person has every trait. How do traits map to the different diseases? So in these studies, we found that on average, people with severe asthma or COPD have 10 distinct treatable traits. Didn't really matter what their diagnosis was. Whether it was asthma, COPD, you still had 10 traits. They were distributed across those ABC domains. And there was an association between the number of traits and the extent of impairment to quality of life. So that on average, every single trait you acquired, you got a clinically significant impairment in quality of life. And as Ian said, we have two key studies that encourage us that this is an effective approach to treatment. This is Vanessa's study in severe asthma, where people were randomised to usual severe asthma care or a treatable traits approach. And the number of people who got a clinically significant quality of life benefit was almost double with the treatable traits approach. So these are strong arguments for adopting treatable traits. But there are roadblocks. Here's a poem about the roadblocks. And often when I present about treatable traits, the response I get from clinicians is it's too hard. So don't tell us that treatable traits is a new paradigm, because the reality is that regulators won't support it. And don't trust anyone who says that we demand better asthma outcomes, because I'm living my life with asthma. In the CRE, we want to read this from the bottom to the top. Because I'm living my life with asthma, we need to demand better asthma outcomes. And don't trust anyone who says that regulators won't support it, because the reality is treatable traits is a new paradigm. So don't tell us that it's too hard. So people with asthma are telling us they want individualised treatment. The science is showing us the benefits of personalised medicine, and the treatable traits approach is offering us a practical way to do this. I want to know what this CRE is going to do. I want to know what it's going to deliver. And I'm going to get off the stage and let someone else answer that question. Thanks.
Thank you, Peter. That was some fantastic insights there. I would now like to welcome back Professor Vanessa McDonald to conclude our session today, and she's going to present on Treatable Traits, the Centre. Thank you, Vanessa.
Thanks, Vanessa. So how is that? How do you top that poem? So the centre itself, I should tell you, it's funded by the National Health and Medical Research Council as part of their Centre of Research Excellence scheme. This is a 5-year grant, and it has a number of objectives. So we've been talking about science and generating new knowledge, but that's not our only objective. It's a big part of it, yes. And what we aim to do is develop new knowledge by testing the impact of treatable traits on patient outcomes and identify health-related economic benefits. With this, we have some other aims, and that is to develop ways of implementing this new knowledge into practice. So one of the problems with research is that it takes a long time to be translated to practice. So we'll have a real focus on doing this, and we'll do it in a number of ways. We'll look at new implementation tools that we can use to implement into the new models of care into practice, new technologies, and we'll inform policy and practice. We have a focus on training the next generation of clinicians and researchers in this approach. So we'll be offering world-class training opportunities for researchers, and I showed you earlier the number of fellows that we've recruited as well as PhD students. But we're not only training researchers, we also have a goal of training clinicians in this new approach to management. And there are a number of ways that we will do that, and I'll show you on another slide. And our final objective is to enhance the national and international collaborations that we have in treatable traits, but also to develop new ones so that we can offer cutting-edge research. So I might start with generation of new knowledge. So we've thought about this centre looking at two different themes. One is a clinical trials platform, which will include RCTs of targeted approaches to care. We'll look at this in a number of different populations. There'll be severe refractory asthma, which is complex and difficult to manage. Then there's difficult to treat asthma, which is also difficult to manage, but might be addressed by addressing extrapulmonary and behavioural factors. We'll look at moderate asthma as well as asthma in pregnancy. In our second theme, we want to focus on generating new knowledge in traits that don't have as much evidence associated with them. And they're things like vocal cord dysfunction. So how can we better diagnose? How can we better diagnose VCD, vocal cord dysfunction, allow patients who experience this condition to have a better journey through the healthcare system, access treatments, and come out with improved outcomes. We want to focus on physical activity. A lot of research has been done on physical activity in other airway diseases in the general population, but not so much in an asthma population. We know that people who are less physically active have worse outcomes, but we don't know what targeted approaches to care can improve those outcomes and change behaviour. And we want to look at side effects of treatment. This really relates to macrolide or antibiotic stewardship programs and oral corticosteroid stewardship programs so that we can optimise practice and reduce side effects associated with these medications. Now, in addition to the research plan that we've proposed as part of this centre, we also want to generate new ideas. And part of our training will allow us to do that. In terms of the promotion of effective transfer of research outcomes, we'll be doing a number of activities to allow this. We've already been talking today about some roundtable discussions looking at asthma and pregnancy. We'll be developing position papers, and we had a meeting last night around vocal cord dysfunction and some of the work that we'll be doing there. And we'll be doing systematic reviews. We'll be developing tools for clinicians as well as patients and presenting these in really easily accessible support materials such as infographics. We'll be developing algorithms for how to approach treatments and developing online health apps that are associated with these algorithms. We're planning an online course in treatable traits through a massive open online course, and we'll have website content that can be accessible by anyone. There'll be webinars, and there's a number of webinars that we've already got planned. And we'll be looking at providing education for novel treatments and how to implement these into practice. I mentioned our training and development for the research and education affiliates and the workforce in general. And we've got a really innovative plan for that training approach. This will include masterclasses where we bring experts together with smaller groups of clinicians and researchers to enhance their knowledge and improve their practice. Similarly, there'll be preceptorship programs where our fellows, trainees, student candidates within the centre will be able to go to other centres that are practising in this treatable trait approach in order to develop new skills. We've got a really exciting career development acceleration program which will fund our Scholars of Excellence to go to international centres as part of the CRE, but we might have that on hold for a couple of years. And finally, we'll have these Innovate workshops where we'll have people generate some innovative and new research questions, and we'll have a room full of people who can enhance that question, and that will be tapped on the shoulder to say, I think this might be an area that you'll be really interested in. Let's support this early career researcher to develop this idea, to bring teams together, and to support that work with some pilot funding. So I think that'll be lots of fun to do as we go forward. And I think for the audience in general, we have a lot of people online who might be really interested in accessing our online programs. So we'll be doing annual research programs or annual scientific programs and offering that both face-to-face and virtually. I've already mentioned the webinars and the seminars. I've mentioned the online courses, and I've mentioned the apps. So how do you know about these things? Well, hot off the press as about 2:30 this afternoon maybe, we let our website go live. And this is www.treatabletraits.org.au. So this is the first time it's been shown in any public domain. Is it going to work if I click the link? Ooh. So this is our website, and as I said, it's been down to the wire all week, making sure we were going to have this ready for this evening. I think it's beautiful. It's also filled with lots of really great content, and it will be continued to be developed and filled with content so that people can see what kind of training and development opportunities will be available. Ooh, Vanessa Clark. So I'm just going to scroll through a few things. I won't spend much time on this. You'll see the types of events that we'll be hosting. And already we have 5 webinars that we've got planned to deliver throughout May and through to July. And that will continue to be populated. We have our research themes and a little bit about what we plan to be doing as part of the CRE. We have who we are and our collaboration map, which we hope that will end up with lots more red pins. And you can see all our team, which is quite extensive. And we have a little bit about who we are and a number of other different pieces of information. So I encourage people to go to our website, have a look, and find out as much as you would like to know about the centre. In addition to the website, however, we're also, we're up with the times. So we have our social media activities. We have a Twitter page at Traits CRE, and we've been featuring Traits of the Month on Twitter, and that gets lots of interest. And yesterday we launched our Instagram page, which will be more of a visual kind of representation of what we're doing and what we're up to. And I'm sure those sites are being quite active this evening. So that gives you a bit of a whirlwind tour of our plans over the next 5 years and beyond, because we hope that this centre will live during the time of its funding period, but also beyond that. So I'd just like to conclude by saying a few thank yous, and if you'd excuse me, I've got a couple to go through. So I think getting the CRE funded to this point involved a lot of work from a lot of people. And I'd like to give special thanks and acknowledgement to all of the CRE investigators for working so wonderfully and collaboratively in the development and now the startup of the centre. I'd also like to acknowledge the bodies that funded the pilot studies and the smaller research areas that allowed this research to develop. And specifically, I would like to acknowledge the John Hunter Hospital Charitable Trust, HMRI, the University of Newcastle, the Lung Foundation of Australia, the Thoracic Society of Australia and New Zealand, and Asthma Australia, who have provided seed funding for this body of work for the last 15 years. Thank you, of course, to the NHMRC for funding the centre and all of the support that they've given to our previous work, and to the Ramaciotti Foundation, who's also been very generous in supporting our work. Now, all of this would not have been possible without the participants volunteering for the research studies. So I'd like to express my gratitude to each and every one of those. And also to our consumer reference group. It's been an honour and a joy to work with you in co-developing the research and in working with your continued expertise and advice. Nearly there. Since establishing this centre and the lead up to the launch, we've been supported by an amazing team of professionals, and they've been instrumental in bringing this all together. So I'd especially like to thank our executive team of the CRE, Vanessa Clark, Naomi Fibbins, who's probably working, oh, there she is, and Peter Gibson. I'd also like to give a special thanks to Olivia Lewis up the back for her creative concepts and staying up late, making sure she ticks all the boxes for me. Rebecca McLaughlin for her work and contribution to the website content and the development and review of the work. The entire research teams of myself, and I'm also going to thank the entire research teams of Peter. And finally, to the people who made the launch what it is. That is the speakers, John, Ian, Peter, Vanessa. To Olivia again for the audio visuals tonight, Cody Garmeister, Tegan Grace, who worked with us in the development of the CRE, the HMRI communications team, Andrew from Oxweb Design, and Andrea, Jackie and Darren from Bounce for the branding, which is beautiful, and the website. And that is all.
That is fantastic. So now I would invite everybody to get involved and ask any burning questions that you have in relation to treatable traits. I believe, Paola, there was one online.
Yes, I've got one. Do you envision that a treatable traits approach will be used in other medical conditions?
Yes, it will. It already is. So we're seeing publications in the respiratory literature about looking at this in sleep apnea, in lung fibrosis. So there are other serious lung diseases. And I think other disciplines might take it on.
Any other questions? Any other questions in the room? Just give the online people a moment. They have to type things in.
There's a lot of congratulations.
Just ask one. When this, as a patient, where would we go to get this? Do we go to our usual rapid access clinic or?
So I'll repeat that question in case you didn't hear it online. This is from a patient perspective. Where would they go to get this type of treatment? A rapid access clinic or a different type of clinic?
You want me to answer? Thanks, Ruth, for you go to Oxford, Peter said. So I think the Severe Asthma Clinic has been doing kind of this type of approach where people are being, I guess, what we call subtyped or phenotyped in terms of different inflammatory subtypes, and then treatment is directed that way. And there are other kind of targeting of comorbidities. But one of the things that we need to focus on is how we can implement this into practice more widely so that people like you can actually access it when you turn up to the clinic. So I think it's a moving ship, and as time goes on, it'll be much more accessible, we hope.
Thank you.
Any other questions online or from the floor?
This is just an online question. Looks great. Have there been discussions with regulators yet? How is this approach being perceived?
Okay. Ian, would you like to answer that for us?
Yes, there have been discussions, but we've got a little bit stuck. And I think this is one of the problems with guidelines is that it can be very difficult to make the sort of large change that we have in mind. Regulators in terms of drug developers, so the FDA, have been very reluctant to make any changes to their concepts of disease because the major guideline groups, GINA and GOLD, have not made these changes. So we're slightly stuck. Somebody has to move first. And I must admit to being a little bit perplexed by the inertia and how difficult it has been to move this forward. And, we tend to scurry back into our comfort blanket. So, this new way of thinking was necessary to discover the efficacy of biologics. But having done that, everyone then retreats back to the position they used to hold. I'd be very interested in whether Richard Beasley had any comments on this, because it's something I know he's thought about as well. Yeah.
Hi there, thanks, Ian, and good evening, everyone. I mean, I think I share your frustration, Ian, that we've really hit a bit of a roadblock in terms of changing guidelines and regulatory thinking. And I think this is why the CRE is so important, because I think we need to actually gather more evidence, particularly from randomized controlled trials that can actually provide the evidence base that we can move forward. And I think that this is encouraging in terms of this initiative.
Yeah, I agree with that. Yeah, definitely. What do you think, Vanessa and Peter?
Yeah.
I agree with you about the sort of to and fro between regulators and guidelines. They sort of blame each other. We have in Australia, we have the same thing between our state and federal governments. They blame each other when they want to avoid a problem. But I am seeing guidelines move, but they're not moving. They're moving using treatable traits concept, but not labelling it that way. So if we can live without being recognised for that, I think we will see guidelines move. And I think for regulators, I don't know the answer there. It'll take persistent pressure probably.
And I guess, if we think about severe asthma and our access to, say, biologic treatments here in Australia, part of the treatable trait approach is to think about the disease as a label-free, or think about label-free. However, when we go to access treatments, we have to ensure that the patient has a diagnosis. So I think we're a bit stuck in areas like that as well.
Any further questions from the floor? Sure.
When this sort of happens and it gets moving along, will this come back to your local GP? Can you access it? Will they be given information?
So, Ruth, I guess there's a couple of things there. One, if you saw that slide I had on the different populations that we're working on, one of the things about this approach is that it might need to look different in different settings. So a real area of focus is, well, what does treatable traits look like in the primary care setting? And that's part of what we're about is to generate some research in that area. But the other thing you're asking is, how will GPs access this information? And that's another real objective of our centre, in that we'll have a key goal of making sure we can get information out there to primary care providers. And we'll do that by contributing to guidelines that people were speaking about earlier, which kind of inform practice, but also through our website in terms of generating information and tools to show different settings and areas how you can implement this approach differently.
Thank you.
On that note, I think that's a really fantastic way to wrap up. So I want everybody to join me in thanking the speakers and celebrating the centre. Thank you all for your time this evening and this morning, depending on where you are in the world.
Would you like a virtual toast, Ian?
Yeah, it might be a bit early for me to get the wine out. Enjoy. I wish I was there with you. And congratulations.
Thank you. We done? Okay. Where shall we adjourn?